I'm on my way to see Tom Earnshaw, LCSW, and I can't wait to see the kind of work he's doing. So Tom, thank you very much for letting me come to your office and ask you a few questions. Your office looks beautiful.
Well, thank you so much. I was when I saw your posting there on Facebook, I thought that is awesome. And then the fact that you have the same position with Texas chapter of ACT that I had, I thought, hey, great.
Oh, yeah.
Must be a good thing.
Definitely. Yeah, passing the baton a little bit here. I don't know. Yours was a little bit further back, right, than mine?
Initial, yeah. I don't know how much I did defer to the cause, so not much of a legacy to live up to.
Oh, cool. Fantastic. So Tom, you've worked in hospital settings for some time. What do you think the biggest factor is in preventing rehospitalization?
It's continuum of care. Basically, we want to boil it down. You know, we were all taught in grad school. You have inpatient, partial hospitalization programs, IOP, intensive outpatient programs, and then outpatient. But we've skipped the middle two there. You know, we don't have that. We just have them go from inpatient, and sometimes they were brought in by the cops, by the sheriff's department. They feel like their family betrayed them on a mental illness warrant, any number of things. And then we as providers, we teach them all this stuff and try to get all this in their head, and then, I mean, it'd be like if I gave you a video on how to parachute.
Okay.
And then I said, okay, great, you've got it, right? And I open the door to the airplane and say, okay, have fun.
I see.
That's essentially what we're doing.
Yeah, no instruction or anything.
No, just like, oh, here are all these really helpful tips, but have fun. And then we wave and we go, oh, I hope you pulled the chute. You know, we're kind of just hoping.
I see, perfect, yeah. Because I know in some settings, right, there is a transition in place from hospitals to, I guess, just outpatient. Are you saying there should be something in between?
Well, no, there is something in between. You know, there's partial hospitalization programs, which is usually 5 days a week, up to 4 to 5 hours a day, and you see a psychiatrist about once or twice a week. Then you have intensive outpatient, which is less time per day or fewer days a week, and then you see a doctor about once a month to titrate the medications.
That's
and then there's outpatient, where you just go, like we all see on TV and everything, you go once a week to the therapist, once a month to the doc. And so the structure's in place for it, we're just not utilizing it.
It's just those two in the middle
there.
Yeah,
those two in the middle we just forget about. You know, we think, oh, we will, but we did, you know, an extra week of inpatient, they should be fine.
Yeah, and I've been seeing that on my end as well, in places that I worked, definitely.
Yeah, we just drop them. Sad. I mean.
How do you think mental health care has changed in hospital settings since you've been working?
It's more acute. It's the people we see when I first started with all of it. I mean, we would see people who were in crises. They were more manageable crises. You know, it was somebody who was really, you know, depressed, or they had just started to display psychotic features, or they were in early stages of mania. And now we see them and they are just full bore into it. And we're just left kind of just trying to stop the bleeding, if you will. You know, we're just trying to patchwork it and trying to get it to, you know, be okay. So I think it's just the level of acuity that we see in the hospital is just skyrocketing and kind of taking us all by surprise, you know, because we were used to the I'm going to kill myself, and you know, that we're used to, as sad as it is. We're used to how to deal with it, but not the full-blown middle of a psychotic episode or manic episode thing. I'm
wondering, you know, do you have any idea why that is? I mean, is it the full moon or something happening, or what's going on there?
Well, I mean, you as well as I know that, you know, full moon is actually like a real thing. I'm going to look at the camera. Yes, it's a real thing. But I think it's more lack of access in the community to places, and then just a general lack of education. about it. You know, it's really hard to get people to come and want to seek help before it gets to the point that it needs a hospital intervention, when there's not really a good structure in place for it. And I think that's just, it saddens me, because we're such a big area here in Dallas, and we should have that available, and that we don't is just, it's demoralizing at some point.
Yeah, I think you're exactly right. And something you said there, I've also seen, I think these days there's less of a stigma around suicidal ideation and things of that nature. So I am seeing more people getting more help earlier on for those kinds of things, so suicide, and then maybe even to some extent like homicidal ideation a little bit there. And then there's these other set of things, that kind of psychosis that you were talking about, that mania, where we really don't have much education of how do we talk about these things in the public or in media.
Well, yeah, and then, you know, I mean, everybody's afraid of it. Everybody's afraid of somebody who has schizophrenia, because there's this idea that they don't know. I've worked with nothing but people who have psychosis for like 2 years when I was at another hospital, and they're nothing to fear. There's nothing better than watching them come out of their psychosis. There's no greater feeling.
Definitely, definitely. And what populations or issues do you work with the most, or like to work with the most?
I like to be challenged. I will work with anybody who wants to come and get help. I'm akin to depression, anxiety, bipolar, and then disorders that have a psychotic element to it, hallucinations, delusion, things like that. I like to help them. To me, it doesn't matter. You know, some therapists identify the LGBTQ population as that. To me, I'm more interested in what are your symptoms and how can I be of a help to that. You know, tell me what your symptoms are, and I'll tell you if we're the right fit. We have a couple sessions. If it's not working out, you tell me.
I see.
I'll help you go find another therapist. I don't. Not that I don't care. I just don't have any skin in the game. The game is to get you better. And so if you're not getting better, then what help am I doing? So tell me what your symptoms are, and I can see if I can help out. If not, I'll help you find somebody who can. That's my thing with who I like to treat.
You talked just a second ago about this importance of education in mental health care, just in general, you know, for the lay population. How do you think we make education better? I mean, what do we do as mental health professionals to help the lay population, media, things like that, talk about mental health?
I think just being asked to come to the table, just being asked to be a part of, okay, if we're going to shut down Tent City, you know, as Dallas did here a couple months, maybe a year back, you know, let's have us be part of the conversation to see how that's going to work and educate on those things. We have really great educational, you know, organizations here in Dallas. We have NAMI, we have MHA America, there's the Jewish Community Services, Catholic Charities. We have really great, really great organizations, and I think we just kind of need that airtime to be able to get out there and say, everybody needs to see a therapist at some point in time. You know, these aren't like odd things that are happening. You know, my favorite thing to do is to convince somebody who is sure they've never had a hallucination in their life, get them to realize they have, and that it's okay, that everybody has it. You know, everybody has something mental health, and everybody can benefit from coming to talk about it, to just be open and honest with themselves and with others. We're all good people at heart.
How can we make the process of access to mental health care easier for clients?
Funding. Plain and simple. I don't like to talk money. It's not a favorite thing, but let's just be really realistic and keep this one short. Funding. Just tons and tons of it.
Yeah.
To just throw at it to see where it goes, because each community is different. What they do in Austin isn't what we can do here, is what we can't do in Houston. So we just need to throw money at it, figure it out, do some studies. But it all boils down to money, unfortunately.
I'm curious, what are some of the things that you're excited for in the future of psychotherapy?
I I don't know. I'm excited by everything. I'm excited by research out of Denmark, and the Scandinavian countries in general are way ahead of us. Australia as well. I love reading those articles and finding out that, oh my gosh, if we just like put people in a community setting and where it's open and they can talk about their mental health, they get better sort of organically. It's very Rogerian in that respect, that it just kind of organically happens. And so I think the research out of there, and the research especially on ACT, is what motivates me and gets my interest, because it just makes sense to me. Yeah, it's really interesting what you do when you go back to funding. If you put money into it, it's amazing what can happen, and it's amazing how simple it seems in retrospect. To, oh my gosh, if we just done this like 2 years ago, maybe we'd be further ahead. But that's okay, as long as we start doing it now.
And are there any non-traditional therapy practices that you engage in, something other than just sitting down and talking?
I don't know if I do anything really horribly untraditional. I do meet the patient where they are. I'm not one who's afraid to, if I have someone sitting across from me and they're talking about this situation, I'm one who is not afraid to just turn into that curve with them and just holistic acceptance, and then hopefully by joining them in their journey where they are, literally where they are. If they're cursing like a sailor, I'll curse like a sailor. If they don't want to curse, I don't curse. I got to meet them where they are to get them there. And I think that's more paramount than really anything else. Is in the climate we have here, people they feel like, oh, I don't want to tell you about it. And if you can just sit next to them, and have them go, hey, look, it's okay. So I will literally, I know we're sitting on the couch, I will literally come sit right next to them. They usually sit where I'm sitting. I'll come sit down next to them, ask their permission, obviously, and say, okay, hey, what's going on? Let's break this whole I have to be across from you thing.
Exactly, right? So you're not the kind of traditional buttoned-up therapist, I guess.
Well, I mean, I wear a buttoned-up shirt.
Okay. But
it's more because it's from Amazon and it's nice.
Sure. Yeah. No, you're right though about that changing up the kind of the flow and meeting them where they are. I think there is something to literally looking at things from the same kind of point of view. Sitting next to them and just kind of looking at the same space, from the same direction. Is a big part of it. You're kind of working as collaborators there, shoulder to shoulder.
I mean, that's what we are as therapists. I don't know anything magical that the client doesn't know. They know more than I do. I went to college, I learned some stuff, I keep myself educated, but when they come in, it's their show. I'm just privileged to have them show up and think that this weird guy can help them out. So I got to join them. They're the expert.
So what does a typical session with you look like? Do you follow a certain structure, or is it more free-flowing?
I can imagine every professor I've ever had cringing at my response of this, but no, I don't have a structure. I get around to the questions in an organic manner. If they want to come in and they want to talk about whatever it is, I'll give them rope. It's what they need. We're constantly building rapport. I don't think that ever stops. In school we were said, you need like 3 to 5 sessions to build rapport. Hogwash. You're always building it. And so there's not really a traditional session. It's what do they come in, what do they need out of that session? There's an overarching goal, but we have smaller goals that meet the bigger goal. So it's whatever they need.
Yeah, exactly. I agree with you there about the rapport building. In fact, I don't really even make it an aim to build the rapport. Some therapists come in like, okay, the first few sessions we're going to be building rapport. It happens from second one. The very first meeting with the person, you're building the rapport. And it happens naturally. I mean, ideally,
the second they call on the phone, that's when you start building it. The second they do it, and so I just try to make it as open, as easy as possible, and I'll go back to they can fire me. I make it so easy to fire me. I'll help them find another therapist. I encourage it, because if it's not working for the client, then what am I doing in the session? I'm collecting a copay and no one's getting any better, and ugh.
Yeah, so when the fit is right, the rapport comes very naturally. It's easy, it's not something you have to work on.
Yeah, no, it's not struggling with it.
If you are, that's a sign. Right?
Yeah, it is.
Tom, thank you very much for letting me come in and talk to you for a bit. It was a pleasure talking to you about your work.
Oh, absolutely. I thank you very much for, doing this for all of us in the area and helping to get all that out there through YouTube and all of that. I think it's just a fantastic thing, and I couldn't be happier to be a part of it. Okay, so here's my pro tip, if you've made it all the way through the video. Here's mine. Admit when you got outside of your head and weren't listening to the client. Just go ahead and admit it to them. They're very forgiving, and it makes it humanizing to you. There's no sense in sitting there and going, yeah, so tell me more about that, trying to catch back up. If you sit there and go, hey, man, I was thinking about the Rangers game last night. Can you tell me that again? They're much more forgiving, and plus it provides an example of how you get constant opportunities to re-engage with your values in the present moment. So, pro tip, just be honest. Hey, we're just people. Like, this is just me here, nothing special or scary or anything. Just a guy with some knowledge who wants to help out other people.